Welcome everyone. Today we're going to talk about something that affects every one of us in clinical practice, the rise of artificial intelligence in medicine. AI tools have already entered our clinics. They're listing diagnoses, suggesting tests, and proposing treatments. This is not a future scenario. It's happening right now in real time. But here's the critical question. How do we preserve our clinical wisdom, our judgment, our intuition, our responsibility to patients in this new age of AI? The subtitle says it all. Trust, verify, and the preservation of judgment. That's the framework we'll explore today. Let's start with a fundamental truth about AI in medicine. They are fast, they are not careful. AI tools operate at unprecedented speed. They can generate a list of medical possibilities in seconds, differential diagnoses, treatment options, drug interactions. It's genuinely impressive. But here's what we need to remember. Speed is not accuracy. These tools lack the nuance of clinical responsibility. They don't know the patient sitting in front of you. They don't see the worry in a family member's eyes. They don't weigh the risks the way a trained clinician does. And that's the reality. That careful, nuanced judgment, that is our job. AI can assist, but it cannot replace the clinical responsibility that each of us carries. Now, let's talk about how to evaluate these AI tools. Not all AI assistants are created equal, and we need to assess them on what matters most to patient safety. There are three critical dimensions to consider. First, accuracy. How often does the model hallucinate or misinterpret medical terminology? This is the foundation. If an AI tool frequently generates fabricated information or misunderstands clinical terms, it's a liability, not an asset. Second, transparency. Can the tool cite its sources, or is it a black box? If you can't trace a recommendation source, you can't verify it. And if you can't verify it, you shouldn't trust it. Third, data protection. Is patient data kept private, or is it being used to train the model? This is not just an ethical concern. It's a legal one. We must ensure that any AI tool we use respects patient confidentiality and complies with data protection regulations. These three criteria should guide every decision about which AI tools we adopt in our practice. This slide illustrates a critical comparison: the idea versus the evidence. On the left, we have AI-powered search, what I call the generator. When you ask an AI chatbot about a patient with chest pain and shortness of breath, it quickly generates a differential. Pulmonary embolism with high probability, pneumonia with moderate probability, aortic dissection with low probability. It even suggests a broad treatment pathway: anticoagulation, antibiotics, imaging. The strength here is obvious: rapid synthesis. It lists diagnoses and proposes broad treatment pathways in seconds. But the weakness is equally important. There is potential for fabrication. The AI may present information with confidence that it doesn't actually have evidence to support. On the right, we have the traditional evidence-based search, the verifier. This is peer-reviewed literature, gold standard diagnostic protocols, randomized controlled trials. The strength is clear. This is reliable, verified, peer-reviewed data with real accuracy. The weakness? It's time-intensive. The takeaway is not to choose one over the other. Use the AI as your idea generator, then verify with the evidence. That's the workflow that keeps patients safe. I want to leave you with this powerful message. Your judgment is still the most important thing. They don't need to become AI experts. They don't need to understand algorithms or neural networks. What they need is to use technology intelligently and verify efficiently. Think of it this way: AI is a tool, just like a stethoscope or an imaging machine. The tool does not make the diagnosis. You do. The tool does not decide the treatment plan. You do. The tool is not responsible for the patient's outcome. You are. Our goal is clear: to improve patient care through the human management of digital tools. We embrace technology, but we are guided by our clinical judgment. Trust but verify. Use AI as a creative second opinion. Confirm each suggestion with proofs. And never forget that the patient in front of you trusts your wisdom, not the speed of a machine. Here are our learning objectives for today's session. First, we want to recognize the role of AI assistants in clinical workflows, understanding where they fit and where they fall short. Second, we'll compare leading AI tools on 3 critical dimensions: diagnostic accuracy, source transparency, and patient data protection. Not all tools are equal, and knowing the differences matters. Third, we'll evaluate AI-powered literature search tools versus traditional PubMed searches. Each has strengths and weaknesses that we need to understand. Fourth, we'll apply a structured critical thinking checklist to AI-generated clinical suggestions, giving you a practical framework you can use tomorrow. And finally, we'll integrate the trust but verify principle into everyday practice, using AI as a rapid second opinion while always confirming outputs against real evidence. This slide provides an overview of the key segments we'll be exploring in this presentation. As you can see, our discussion is organized into 3 main areas. First, we look at the evolution of AI, tracing the journey from its beginnings through modern AI and into emerging trends and challenges that lie ahead. Second, we dive into navigating AI scientific search engines, examining the landscape of AI-powered tools, including platforms like ChatGPT and others, that are transforming how we access and process scientific information. Third, we explore the AI-assisted clinical pathway, a practical step-by-step approach to integrating AI into clinical decision-making. This includes prompting the AI effectively, reading and interpreting its answers, verifying the information against trusted sources, and ultimately applying critical judgment to reach sound clinical decisions. Each of these segments builds on the previous one, taking us from foundational understanding to practical application. Let's begin by looking at how AI has evolved over time. Let us start with introduction and clinical. How are these AI assistants when making clinical recommendations? This sets the stage for the detailed evidence we'll examine in the coming slides. This slide presents a timeline of the AI revolution in ophthalmology, showing how rapidly this field has evolved. In January 2023, we saw the first key comparative study, the initial peer-reviewed evaluation of AI in ophthalmology. This was a landmark moment that gave us our first rigorous data on how these tools actually perform in a clinical specialty. By mid-2024, there was a noticeable surge in clinical AI research output. The field was generating studies at an accelerating pace, driven by both academic interest and commercial investment. Then came the transition to multimodal models, the shift from text-only to image-integrated AI within just 36 months. This is particularly significant for ophthalmology because the specialty relies so heavily on imaging, fundus photos, OCT scans, visual fields, and by October 2025, we hit a data explosion, a rapid expansion of the evidence base for multimodal clinical AI. The speed of this evolution is remarkable. What took decades in other medical technologies is happening in months with AI. And that speed is precisely why we need to be thoughtful about how we evaluate and adopt these tools. Look at the data. By mid-2024, there was already a noticeable acceleration in peer-reviewed publications on AI in clinical settings. The research community is racing to keep up with the technology itself. This slide introduces an important milestone. 6 commercial language models are currently facing clinical evaluation. These are not experimental research tools anymore. These are commercially available products from major technology companies that are being rigorously tested in clinical settings. The fact that 6 models are being evaluated simultaneously tells us 2 things. First, the market is competitive and moving fast. Second, we now have enough tools to compare and contrast, which means we can start making informed decisions about which ones are suitable for clinical use and which are not. As we will see in the coming slides, performance varies significantly across these models, and not all of them meet the bar for clinical reliability. This slide continues with the standardized ophthalmic knowledge theme, again showing that AI approaches the expert median. The bottom annotation reinforces this key finding. By reaching the expert median, AI demonstrates it can perform as well as the middle 50% of human specialists. This is now the 3rd time we are seeing this benchmark emphasized, and for good reason. Consistency is one of AI's greatest strengths in clinical settings. While human experts may vary in their performance depending on fatigue, time pressure, or familiarity with a particular condition, AI models deliver the same level of performance every single time. That consistency has real value in settings where access to specialist expertise is limited. Now let us look at the actual performance data. This slide presents the head-to-head comparison of the 3 leading models in emergency triage. Claude Opus leads at 87.5%, followed by ChatGPT-5 at 85%, and Gemini 2PAF Pro at 80%. All 3 showed broadly similar performance across cornea, retina, glaucoma, orbit, and neuro-ophthalmology emergencies. Critically, errors were predominantly partial diagnoses rather than catastrophic misses. These numbers represent a real clinical milestone. We are now in a range where AI-assisted triage becomes practically useful. Here is our subspecialty heat map showing the detailed breakdown. Look at the color coding. Green for high-performance areas like general ophthalmology, retina, and glaucoma. These are backed by 10 to 18 studies showing strong diagnostic and treatment recommendations. Yellow for moderate performance in neuro-ophthalmology, cornea, and oculoplastics. And red for significant data gaps in pediatrics, rare diseases, and guideline adherence. The critical takeaway here is at the bottom. No single model is universally superior across all tasks. Performance maps directly to the volume of training data available for that specific subspecialty. This has direct implications for how we should deploy these tools. This is our agenda transition slide. We have completed our discussion of introduction and clinical evaluation and performance and diagnostic accuracy. Now we are moving into section 3, multimodal diagnostics and limitations. This is where things get really interesting because we shift from text-based evaluation to the real-world challenge of interpreting images. After this section, we will cover error analysis and risk management, and finally evidence gaps, standards, and safe deployment. This slide presents a comparative overview of the top frontier multimodal AI models currently available, which form the foundation of the diagnostic tools evaluated in this study. The table highlights 4 leading model families: First, GPT-5.2 and GPT-5.3 from OpenAI. These models offer advanced multimodal capabilities, including image interpretation, real-time reasoning, and integrated tool use. They are available through ChatGPT Plus, free tiers, and the OpenAI API, making them broadly accessible for clinical research and deployment. Second, Claude 4.6 from Anthropic, known for strong performance in nuanced text and image analysis with an emphasis on safety and reliability. Accessible via the Anthropic API and Claude AI, supporting structured clinical workflows. Third, Gemini 3 from Google DeepMind. Excels in multimodal understanding across text, images, and video with deep integration into Google's ecosystem. Available through Google AI Studio and Vertex AI. Fourth, Llama 4 Maverick and Scout from Meta. As open weight models, these offer flexibility for custom fine-tuning on domain-specific ophthalmic datasets available through open source channels and cloud providers. Key takeaway: no single model is universally superior across all ophthalmic subspecialties. Performance depends on the volume and type of subspecialty specific training data. This reinforces the need to evaluate each model within its specific clinical context rather than relying on general benchmarks. Emphasize that the AI landscape is evolving rapidly. Model selection should be driven by the specific diagnostic task, data availability, and deployment requirements of the clinical setting, focusing on current limitations in visual interpretation. Three critical findings here. First, multimodal AI does boost diagnostic accuracy. Models integrating fundus and OCT images outperform text-only approaches, which validates the multimodal direction. Second, the performance gap versus human experts remains substantial. GPT 4.5 and Gemini 2.0 Pro achieve only 65 and 63% accuracy respectively, while human specialists consistently reach 85 to 97%. That is a 20 to 30 percentage point gap. Third, visual interpretation is the current frontier where AI models still fall short of reliable, standalone, image-based diagnosis. This is the area where the most progress is needed. We have now covered introduction and clinical evaluation, performance and diagnostic accuracy, and multimodal diagnostics and limitations. We are now entering Section 4, Error Analysis and Risk Management. This is perhaps the most important section for clinical practice because understanding how these models fail is essential for safe deployment. We will then conclude with evidence gaps, standards, and safe deployment. Let us start with error profiles and guideline deviations. Three important findings. First, partial diagnoses are common. Models often miss one or two critical steps in management plans. They get the main diagnosis right, but may omit an essential follow-up step or imaging order. Second, and this is particularly insidious, readable output masks errors. These models produce highly structured, professional-looking clinical notes that can conceal underlying clinical mistakes. The output looks so polished that it can create false confidence. Third, guideline deviations persist. Deviation from AAO guidelines occurs in 7 to 19% of cases, which is clinically significant. Let us see now evidence gaps, standards, and safe deployment. We have covered the performance data, the multimodal challenges, and the error landscape. Now we need to address what is missing from the evidence base and how we move toward safe, standardized clinical deployment. This is where we translate all of the findings into actionable recommendations. Critical evidence gaps. Three major areas need attention. First, multimodal guideline adherence. There is simply no published data on how well multimodal AI performs against clinical guidelines. We have text-only data, but the multimodal frontier is uncharted territory for guideline compliance. Second, rare and pediatric cases are critically undertested. Current models heavily favor common diseases like diabetic retinopathy and dysglaucoma, leaving rare and pediatric cases with insufficient evaluation. Third, there is an urgent need for rigorous clinical trials. Prospective multimodal studies are essential to validate safety and reliability before widespread deployment. Future comparative trials require rigorous clinical standardization. Three pillars of this standardization. First, standardized case banks. We need to move beyond isolated board questions to multi-subspecialty banks spanning both text and multimodal imaging. Second, simultaneous multimodal testing. We must lock model versions to prevent version drift and test all major commercial APIs concurrently for fair comparison. Third, human-in-the-loop benchmarking. We need to compare AI directly against attending specialists and residents using blinded panels measuring accuracy, completeness, and safety. This is the gold standard we should be working toward. A safe clinical implementation requires a strict human-in-the-loop workflow. Three practical principles. AI is a complement, not autonomous. It excels at drafting notes, generating broad differential diagnoses, and triaging patients, but it cannot finalize medical care. Subscription over free access, professional and paid API versions consistently outperform free, publicly available ones in terms of clinical reliability. An expert oversight, final diagnostic and therapeutic decisions must remain in the hands of board-certified specialists. This is the operational framework for our responsible deployment of AI in ophthalmology. This is our closing statement. The immediate future is supervision, not substitution. Let this resonate. Large language models are rapidly approaching expert-level clinical reasoning, but they still lack expert-level reliability. To harness their potential safely, they must be deployed as clinical adjuncts under uncompromising human oversight. This is not a temporary position. This is the responsible framework for the foreseeable future. And now the practical question everyone has been waiting for. Where do I go from here using AI to help with diagnosis and treatment? This is the transition from evidence review to practical guidance. We have seen the data, high accuracy, but imperfect reliability, multimodal limitations, hallucination risks, and the need for oversight. So how do we actually use these tools in our daily practice? The answer lies in understanding what AI does well: drafting, differential generation, triage support, and where it needs human expertise to fill the gaps. Now you may want to pause the video and take a look at this table. And this is where we bridge from evidence to action. This final slide introduces our practical guide, leveraging LLMs as clinical diagnosis and treatment assistants. Everything we have discussed today, the 80 to 87% diagnostic accuracy, the subspecialty variability, the multimodal limitations, the hallucination risks, the need for human oversight, all of this informs how we should actually use these tools in our daily practice. On the left, you see the core concept: patient data flowing through AI analysis, combining clinical text with imaging data, processed by a system that integrates neural network reasoning with established medical knowledge. On the right is the practical workflow: structured testing protocols feeding into clinical integration with human oversight at every step. The key message is this: we are not asking whether to use AI in ophthalmology. That ship has sailed. The question is how to use it safely, effectively, and responsibly. This guide provides that framework. Use AI for what it does best: drafting clinical notes, generating differential diagnoses, supporting triage decisions, and synthesizing complex patient data. But always verify against your clinical judgment, always check against AAO guidelines, and never let the polished output of a language model substitute for the trained eye and mind of a board-certified specialist. Remember, supervision, not substitution. The technology is remarkable and rapidly improving, but the ophthalmologist remains irreplaceable. Thank you for your attention, and I look forward to your questions. And now, the practical question everyone was waiting for: what do I do from here to use AI as an aid in diagnosis and treatment? This is the transition from evidence review to practical guidance. We've seen the data: high accuracy but imperfect reliability, multimodal limitations, hallucination risks, and the need for oversight. So, how do we actually use these tools in our daily practice? The answer lies in understanding what AI does well: drafting, differential generation, triage support, and where it needs human expertise to fill the gaps. The truth is that it is much better to hear advice from several consultants than from just one. In the same way, it's better to analyze the advice from several chatbots than just from one. The reason is that for now there is no one best chatbot. This slide introduces the concept of unified AI-powered chatbots. The key idea is to bring multiple interaction bots into one intelligent chatbot experience. This flow shows how a single prompt is sent to multiple bots in parallel, allowing their responses to be compared side by side in a consistent and unbiased way. This workflow transforms AI from a single source tool into a multi-perspective reasoning engine. Multi-Search Multi-AI is an extension for Chrome. You can download it from the Chrome store. It is a power user workflow that uses several brains and search queries at once to get a more accurate, unbiased answer. This process uses 3 steps. A single question is turned into several specific search queries. Multiple AI models analyze the search results at the same time. A final model combines the findings, checks the facts, and creates a summary. This is like using a team of researchers to review different sources and discuss the information before providing a final report. So, a question that comes up frequently: if AI is so powerful, why do different systems give me different answers to the same clinical question? This is a critical point to understand before you start relying on any of these tools. There are 4 key reasons for this variability. First, training data. Each model, whether it's a GPT-4, Claude, Gemini, or others, was trained on a different corpus of text. They have different knowledge cutoff dates, meaning some may have access to more recent guidelines and literature than others. A model trained through 2024 might reference a newer protocol than one whose data stops at 2023. Second, reasoning architecture. These models don't all think the same way. Their underlying design, the number of parameters, how attention mechanisms are structured, the fine-tuning approach, all affect how they process a clinical scenario and arrive at a conclusion. One model might weigh differential diagnoses differently than another, even with the same input. Third, safety guardrails. This is especially relevant in medicine. Each company applies different content filters and safety boundaries. Some models may decline to give a specific diagnosis or treatment recommendation, while others will be more forthcoming. These guardrails can meaningfully shape the clinical utility of the response you get. And fourth, web access and prompting. Some models can search the internet in real time, pulling in the latest evidence, while others work only from their training data. Additionally, the way you phrase your question, your prompt, is interpreted differently by each model. A subtle difference in wording can lead to substantially different outputs. The takeaway here is straightforward. Treat AI outputs like you would a colleague's opinion. Consider the source, cross-reference when possible, and never rely on a single model's answer for clinical decisions. Let's put this into practice. What actually happens when you take the exact same clinical case and submit it to 6 different AI systems? The results are very revealing. We see meaningful variation across 4 key dimensions. First, differential diagnoses. Not all models generate the same list. Some may prioritize the most statistically common conditions, while others cast a wider net. Critically, a rare but important diagnosis, say a paraneoplastic syndrome or a zebra like pheochromocytoma, might appear on one model's list and be completely absent from another's. That's a clinically significant gap. Second, explanations. Even when 2 models arrive at the same diagnosis, their reasoning can look quite different. One might give you a step-by-step pathophysiological justification, while another provides a surface-level pattern match. The depth and clarity of explanation matters because it's what helps you evaluate whether to trust the answer. Third, suggested tests. This is where things get very practical. One model might recommend starting with basic labs and imaging, while another jumps straight to advanced diagnostics. The scope and priority of recommended investigations can vary substantially, and that has direct implications for cost, patient experience, and diagnostic efficiency. Fourth, treatment options. Different models may draw on different evidence bases, different guidelines, different eras of literature, leading to different management recommendations. One might favor a conservative approach, while another suggests a more aggressive intervention. And here's the key insight at the bottom of this slide. Comparing models doesn't just improve your answers. It highlights where true clinical uncertainty exists. When all 6 models agree, that gives you one signal. But when they diverge, that's telling you something important about the state of the evidence itself. Use that divergence as a diagnostic tool in its own right. Let's walk through 5 critical areas where AI falls short in clinical reasoning. First, missing critical diagnoses. AI models tend to optimize for the most likely answer. That's great most of the time, but medicine isn't about most of the time. It's about catching the one case that matters. A rare but dangerous diagnosis, an aortic dissection presenting atypically a subtle sepsis picture, can be completely absent from an AI's differential. The model doesn't know what it doesn't know, and it won't flag its own blind spots. Second, hallucinated references. This one is particularly insidious. AI can generate citations that look completely real, proper journal names, plausible author names, realistic DOIs, but point to studies or guidelines that simply do not exist. If you're using AI to support a clinical decision and you don't verify the source, you could be basing your reasoning on fabricated evidence. Always check the references. Third, incomplete context. This is a fundamental limitation. AI can only work with the information you provide in the prompt. It cannot see the patient. It doesn't know about the subtle facial grimace, the family member's concern, the medication the patient forgot to mention. All of those clinical nuances that you pick up at the bedside, AI has zero access to them unless you explicitly type them in. Fourth, outdated information. Every model has a training data cutoff. That means its knowledge of the latest guidelines, drug approvals and emerging evidence may be months or even years behind. In fields that move fast, oncology, infectious disease, cardiology, this lag can be clinically significant. A model might recommend a treatment approach that's already been superseded. And fifth, overconfident answers. This may be the most dangerous failure mode. AI doesn't hitch the way an experienced clinician does. It doesn't say, "I'm not sure about this one." It presents uncertain conclusions with the same authoritative tone as well-established ones. That false confidence can be misleading, especially for less experienced clinicians who may not have the background to question the output. The bottom line, these are not reasons to avoid AI. They're reasons to use it with eyes wide open, know where it breaks, so you can catch it when it does. At this point, we've seen where AI fails in clinical reasoning: missed diagnoses, hallucinated references, incomplete context, and overconfidence. Now we move into the core, practical question. How do we safely use AI for evidence search and clinical decision support without compromising reliability? This next section focuses on AI-powered search engines, the trade-offs they introduce, and how to integrate them responsibly into evidence-based medicine. The adoption of AI search engines introduces a fundamental trade-off: speed versus evidence reliability. Clinicians today need immediate access to more than 39 million biomedical records. Traditional Boolean searches, like those in PubMed, are extremely precise, but they are slow, complex, and impractical at the bedside. Generative AI tools solve the speed problem. They retrieve and summarize information instantly. But they also introduce a serious complication: the black box problem. These systems often mix high-quality randomized trials with lower-tier web content, and they can generate claims that sound scientifically plausible but lack real evidentiary support. The solution is not to judge tools by how elegant their interface looks, but by their underlying architecture, the data corpus they use, how retrieval is performed, and how evidence is weighted. Clinical safety depends on evidence quality control and verifiability, not on convenience. Despite all advances in AI search, PubMed remains the non-negotiable gold standard for clinical evidence. Its primary strength lies in rigorous curation by the NIH and NLM, using mesh-controlled vocabulary and dedicated filters for randomized trials, meta-analyses, and guidelines. PubMed is fully transparent. You get a complete bibliographic data, PMEDs, DOIs, conflict of interest disclosures, and retraction notices, all essential for critical appraisal. Its limitation is usability. PubMed has a steep learning curve, requires Boolean logic, and lacks native summarization, making it time-intensive for rapid bedside decisions. That's why PubMed should not be replaced. It should be integrated. Mandatory use cases include updating clinical guidelines, finalizing complex patient management, and resolving medico-legal questions. AI can accelerate access, but PubMed validates truth.
So this is what a consensus search looks like. Here at the top, you have the prompt I've put in. You're a medical research assistant specialized in evidence-based medicine and ophthalmology artificial intelligence evaluation. Your task is to search the scientific medical literature to identify peer-reviewed evidence comparing large language models used as a clinical assistant. This is the search I used for preparing this presentation. This is a short prompt, but really the complete prompt is like this. I didn't write this prompt. I just did what is called meta-prompting. So I told ChatGPT what I needed and asked a prompt to make this search. And this is what it came from. We're not going to read it in detail, but as you can see, it's much more complete than the other one. So once consensus finishes looking, you come up with a summary of what it found. And this is what I asked it: a comparative performance of large language models as clinical assistants in ophthalmology. It gives you first an introduction, and in every paragraph you get the links from where this paragraph was created. So if you want, you can go immediately to the full text or the reference of this. After that, usually it builds a question related to what you were looking for. This one is an important question. Are large language models accurate clinical assistance for diagnosing and treatment recommendations in ophthalmology? And usually it divides it in 4 types of answer. Yes. Here it was 44%, possibly 35%. I mixed and no, a little bit less. If you want more details, you can click down here, and it tells you more about these kind of findings. The next thing you get describes the methods it used, searching, in this case, Semantic Scholar, PubMed, Medline, Scopus, etc. After that, you get the search strategy and what it got, the papers it got, the papers it reviewed, and the ones it finally came up to use. Then you get the results, and here in this first paragraph, it gives you the model comparison across clinical tasks, also with the links to the papers. Then how did it perform in different subspecialties? Also, summary with links to it. How did multimodal and domain-specific models work? The safety risks. And this is something it always does, that it gives you from the oldest paper it took a look at, 2023, to the most recent one in 2025. In artificial intelligence, it doesn't make more sense than looking 1 year back, because it changed so fast that what those papers discovered, validated, probably now it's outdated. Then you get a list of the authors that more contributed to this, and their papers. Here, in this case, Antaki had 4 papers, Gijowski 4 papers, etc. The journals that had more papers around this. Then it comes up with a discussion of the findings, always giving you the links to the papers. Then it classifies the claims and evidence that came up with this. For example, in this case, state-of-the-art LMs match or exceed trainees, junior doctors on standardized exams. And for this, it gave the evidence was strong. Instead, if we go down here, regarding guidelines, discordance or harmful outputs occur at non-trivial rates among some LLMs. Here, for this, the evidence was moderate. Finally, it gives you the conclusion. It gives you the research gaps. This is important to know what is missing, to know about our question. And finally, it gives you the references. If you click here, you get on the side all the references that you can see one by one, and if you want, you can go to them. The other thing consensus allows is to use filters. In this case, for this search, the filters we used were the published year from highly ranked journals. We didn't put only open access. You can do that if you want, but you will get less references. And the methodology we asked any kind of design, because ideally you should look for meta-analysis, thematic reviews, but in such a short period, these didn't come up with many papers. So I preferred to search for all kind of papers. So this is what elicit looks like. Up here, we pasted the same prompt that we pasted on consensus. I always do this in several search engines. So I get more evidence from different AI searching machines. So in this case, the summary it gives at the beginning is a little bit shorter. It tells you the final items. It shared through 70 items usually. This one gives you more papers put into this review than the other one. Initially, they come up with a lot of papers, but then they look in them which are the ones that will give the best answers for what we search and limit their summary from here. So the initial summary is a little bit shorter, but it presents very nice tables, so where you can see the papers and what they presented. And if you come up here, we can see more in the columns. What do they have? It gave us here the key findings, the accuracy, the data sets, the tasks of all these main papers it searched. Then it also comes up with some summaries regarding different topics. In this case, the model performance summary, also with links to the papers from where they got this, what they found about Gemini, Claude, all of the ones we requested to link. Then it comes up down here with a summary regarding safety risks and limitations, also from the main papers they got it. Also, it gives you major research gaps and methodology recommendations for future studies. Finally, this is what perplexity looks like, also with the same prompt we gave the others. As you can see, it's a long prompt. And here you also get a summary up at the top, and it lists initially the more representative studies meeting your inclusion criteria. They name them here and put in the link where you can go immediately if you want to check them. Then it also builds nice tables where they compare the studies. The study, the year, the subspecialty, the models compared, the task. It's a very nice table with several columns that also include limitations, key findings, accuracy. So these summaries are very, very good to read. Then it starts showing papers that answer which models do best by task. And here they come with the papers that covered that. Then which worked well doing differential diagnosis generation, more papers, all with the links to them. So as you can see, the three are more or less the same. They differ a little bit, and I use them all because then I can compare the results, because sometimes some results are unique in one and didn't appear in the other. And so what I do is also with ChatGPT, I review all the results and see what each of these presented as unique and which others they had in common. As you can see here, it also later refers to hallucinations. So it has a very nice way of summarizing the conclusions for reading and understanding.
When using AI for evidence synthesis, strict adherence to safety protocols is mandatory. This slide presents a clinical safety checklist that should guide every interaction. First, appraise the primary source. Never cite an AI summary. Always click through to the original paper and verify it using PMIDs or DOIs. Second, enforce evidence hierarchies. Actively prioritize systematic reviews, meta-analyses, and clinical guidelines. AI tools do not automatically rank evidence by quality. That remains our responsibility. Third, verify currency and consensus, check publication dates, avoid superseded data, and cross-reference findings with current national guidelines such as AAO or ADA. Fourth, audit extracted data. Manually confirm key PICO elements, especially sample size and outcome statistics, against the original abstract. AI should amplify critical appraisal skills, never replace them. Every ophthalmologist should learn to work with AI, and the reasons are structural, not optional. First, volume. Thousands of new ophthalmology papers are published every year. No human can keep up unaided. Second, innovation. New therapies, diagnostics, and technologies are introduced continuously, reshaping clinical practice. Third, complexity. Clinical decision-making is becoming more demanding, data-dense, and time-pressured. AI is not replacing expertise. It is becoming essential to manage information overload safely. AI systems are powerful, but they carry real clinical risks. They can generate incorrect information that sounds convincing. They may omit rare but critical diagnoses. They can fabricate or misattribute references. And their recommendations may be outdated due to training data cutoffs. These are not theoretical concerns. They are documented failure modes. That's why AI must always be used critically, within a structured workflow, and under physician oversight. Physicians who learn to work with AI will have a clear advantage. AI expands diagnostic thinking by broadening differentials and surfacing overlooked possibilities. It accelerates evidence access, retrieving and summarizing relevant studies in seconds. It enhances education by supporting teaching, simulation, and resident training, and it helps clinicians stay updated in a rapidly evolving field. The advantage does not come from trusting AI blindly. It comes from knowing how to interrogate it intelligently. This is where we move from evidence to action. This slide presents a practical framework for using large language models as clinical diagnosis and treatment assistants. Everything we've discussed today, diagnostic accuracy, subspecialty variability, multimodal limitations, hallucination risk, and the need for human oversight, comes together here. AI should be used for what it does best: drafting notes, expanding differentials, supporting triage, and synthesizing complex information. But it must always be verified against clinical judgment and current guidelines. The key message is simple: supervision, not substitution. AI is powerful and improving rapidly, but the ophthalmologist remains irreplaceable. This is where we start turning an AI response into something clinically reliable. The first step is to extract the main clinical claim. AI answers often contain multiple statements, and each one needs to be evaluated separately. For example, when an AI says that anti-VEGF is first-line therapy and that aflibercept is superior in patients with poor baseline vision, those are actually two distinct claims. Each claim must be verified independently. This step is critical because treating a complex AI answer as a single statement is one of the most common mistakes clinicians make. Once the claim is clearly identified, the next step is to start with an evidence-focused search tool, not a general chatbot. Tools like Consensus, Elicit, or Perplexity are designed to retrieve scientific literature rather than generate opinions. What we want from these tools is very specific: a list of relevant articles, the Hattori type, such as guidelines, meta-analyses, or randomized trials, and direct links to the original publications. At this stage, The goal is not interpretation. The goal is simply to locate the best available evidence. After retrieving the literature, we need to prioritize the highest level of evidence. Clinical guidelines and systematic reviews should always come first, followed by randomized controlled trials. In ophthalmology, the strongest sources are often AAO-preferred practice patterns, Cochrane reviews, and large, well-designed randomized trials. Lower-level evidence can still be useful, but it should never outweigh higher quality sources when making clinical decisions. Once a promising study appears, it must be verified on PubMed. This step ensures that the article actually exists and allows us to review the study design, sample size, results, and limitations. PubMed remains the gold standard because it provides transparent bibliographic data and direct access to the original publication. This step protects us from one of AI's most dangerous failure modes, citing studies that sound real but do not actually exist. This step is absolutely crucial. Even when an AI cites a real study, it may misinterpret the findings, exaggerate results, or ignore important subgroup limitations. A classic example is Protocol T. Aflibercept was superior only in patients with poor baseline visual acuity, not across all patients. If the AI claims overall superiority, that statement is inaccurate. This is why clinicians must read the abstract or conclusions themselves and confirm that the evidence truly supports the claim is being made. The final verification step is checking the publication date. Clinical recommendations evolve quickly, especially in ophthalmology. Evidence that is outdated may no longer reflect current best practice or guideline recommendations. Before applying any AI-supported recommendation, we must confirm that the evidence is recent and consistent with current standards of care. This final step closes the loop and ensures that AI accelerates evidence access without compromising clinical accuracy. This slide presents a simple but essential 5-minute evidence verification workflow that every clinician should adopt when using AI for clinical questions. When an AI tool provides a clinical answer, here is what you should do. First, extract the key claim from the AI's response. Identify the core medical assertion being made. Second, search that claim on specialized academic AI tools like Consensus or Elicit, which are designed to query the scientific literature directly. Third, look specifically for high-quality evidence, ideally a meta-analysis or a randomized controlled trial that supports or refutes the claim. Fourth, verify that the study actually exists by looking it up on a PubMed, since AI can sometimes fabricate references. And fifth, read the abstract or conclusion of the actual paper to confirm the findings align with what the AI stated. Finally, compare those verified findings with your specific patient case. This entire process typically takes between 3 and 5 minutes, and it can be the difference between safe, evidence-based care and a potentially dangerous decision based on unverified AI output. Now let's talk about one of the most critical topics when using AI in healthcare: safety and privacy rules. Patient privacy must be protected at all times when using any AI tool. This is not optional, it is a legal and ethical obligation. The fundamental rule is simple: never enter identifiable patient information into any AI system. Let me be specific about what you should never include. First, never enter patient names. Not first names, not last names, not initials. Second, never input medical record numbers or any unique identifiers. And third, never upload identifiable images or data. This includes photos, scans, or any documentation that could be traced back to a specific patient. So, what should you use instead? Always work with anonymized clinical cases, use de-identified findings, describe the clinical scenario without any personal details, and rely on generic demographic descriptors such as a 45-year-old male rather than using actual patient demographics that could identify someone. Remember, once data enters an AI system, you cannot control where it goes or how it is stored. Protect your patients by keeping all interactions with AI completely de-identified. This slide covers the first 6 of 10 common mistakes that doctors make when using AI in clinical practice. Being aware of these pitfalls is the first step to avoiding them. Mistake number 1 is asking vague questions. When you ask imprecise questions without sufficient clinical detail, the AI has to guess or fill in gaps, which leads to generic or inaccurate responses. Always be specific in your prompts. Mistake number 2 is providing insufficient context. This goes beyond vague questions. Providing too little clinical information means the AI cannot engage in meaningful clinical reasoning. Include relevant history, medications, lab values, and the specific clinical question you need answered. Mistake number 3 is trusting the first answer. Many clinicians accept the initial response from AI without critical evaluation or comparison. You should always challenge the output, ask follow-up questions, and cross-reference with your own clinical knowledge. Mistake number 4 is ignoring dangerous diagnoses. This is particularly serious, failing to check whether urgent or life-threatening diagnoses were considered in the AI's differential. Always ask the AI explicitly about red flag conditions. Mistake number 5 is not verifying references. AI tools can fabricate citations that look completely legitimate. Using AI-cited studies without independent confirmation on PubMed or similar databases is a dangerous practice. And mistake number 6 is privacy violations, entering identifiable patient data into AI systems. As we discussed on the previous slide, this is both a legal risk and an ethical breach. Always de-identify before you type. This slide brings together everything we've discussed into a single, structured workflow for using AI in clinical reasoning. Think of this as your step-by-step safety net. It all starts with clinical findings. You begin with your patient, the history, the physical exam, the lab results, the imaging. This is the raw clinical data that you, as the clinician, gather firsthand. No AI replaces this step. Next comes the AI differential. You take those de-identified clinical findings and input them into an AI tool to generate a differential diagnosis. The AI can help you consider possibilities you might not have thought of, broaden your thinking, and flag rare conditions. But remember, this is a suggestion list, not a final answer. The third step is to compare models. Don't rely on a single AI tool. Run the same clinical scenario through multiple AI models, ChatGPT, Claude, Gemini, or others. Where they agree, your confidence can increase. Where they disagree, that's where you need to dig deeper. Step 4 is to verify evidence. Take the key claims and diagnoses suggested by the AI and verify them against the medical literature. Use tools like PubMed, Consensus, or Elicit to find supporting meta-analyses, randomized controlled trials, or clinical guidelines. Never trust an AI-cited reference without checking it yourself. And finally, clinical judgment. This is where the physician's role is irreplaceable. You integrate everything, the AI suggestions, the verified evidence, your clinical experience, and your knowledge of this specific patient to make the final decision. The key takeaway here is that this structured workflow ensures AI enhances, rather than bypasses, the clinician's reasoning process. Evidence verification and clinical judgment remain central at every single stage. AI is a powerful tool, but it works best when it's embedded within a disciplined clinical process like this one. I want to leave you with this powerful message. Your judgment remains at the center. You don't need to become an AI expert. You don't need to understand the algorithms or the neural networks. What you need is to use the technology wisely and verify efficiently. Think of it this way. AI is a tool, just like a stethoscope or an imaging machine. The tool doesn't make the diagnosis. You do. The tool doesn't decide the treatment plan. You do. The tool doesn't carry the responsibility for the patient's outcome. You do. Our goal is clear: enhance patient care through human stewardship of digital tools. We embrace the technology, but we lead with our clinical judgment. Trust, but verify. Use AI as your creative second opinion. Confirm every suggestion with evidence, and never forget. The patient in front of you is counting on your wisdom, not a machine's speed. Thank you. So before we wrap up, I want to leave you with 3 practical things you can try starting tomorrow. These are not theoretical. These are concrete actions you can take with your very next patient. The first one is to expand your differential. Take a current or recent clinical case, one where you already have a working diagnosis, and run it through an AI tool. You might be surprised. AI can suggest diagnoses you hadn't considered, especially rare conditions or atypical presentations. It's not about doubting your clinical skills. It's about using AI as a safety net to catch what might be missed. The second action is to compare multiple models. Don't just use one AI tool. Take the same clinical question and ask it to at least 2 different systems. For example, ChatGPT and Claude, or Gemini and Perplexity. See where they agree and where they differ. Agreement builds confidence. Disagreement tells you where the uncertainty lies and where you should investigate further. And the third thing is to verify with evidence. Before you apply any AI recommendation to a patient, take a few minutes to check it against the published literature. Look it up on PubMed. Use consensus or elicit. Make sure the evidence actually supports what the AI is telling you. This is the habit that separates Xife AI use from risky AI use. These 3 steps, expand, compare, verify, will quickly become second nature, and they will dramatically improve how you use AI in your practice. I want to leave you with this key message. AI will not replace ophthalmologists. Let me say that again. AI will not replace you. The clinical intuition you've developed, the hands-on surgical skills, the ability to look a patient in the eye and make a judgment call, no algorithm can replicate that. But here is the nuance. Ophthalmologists who learn to use AI effectively will gain a significant advantage in clinical practice, in education, and in research. Those who embrace these tools wisely will be faster, more thorough, and more informed in their decision making. Those who ignore AI risk falling behind as the field evolves. The future belongs to clinicians who combine medical expertise with the intelligent use of AI tools. It's not about choosing between human medicine and artificial intelligence. It's about bringing them together. Your expertise amplified by AI, your judgment informed by data, your practice enhanced by technology. So my challenge to each of you is simple. Start small, stay critical, and keep learning. The tools are here. The opportunity is now. And you are exactly the right people to lead this transformation in ophthalmology. Thank you all very much for your time and attention today. I hope this presentation has given you a practical and realistic perspective on how AI can support your work as ophthalmologists, not as a replacement for your expertise, but as a powerful tool to enhance it. If you have any questions, I'd be happy to discuss them now. And if you want to continue the conversation afterward, please feel free to reach out. Remember, start small, stay curious, verify everything, and always keep your clinical judgment at the center. The future of ophthalmology is bright, and you are the ones shaping it. Thank you.